Uh, Good morning, all. Today we are going to say about the female pelvis. So this is very important topic. Why? Because in everything we have to know the basic baseline, right? So by knowing the basic only or a normal thing only, we can able to identify the abnormal thing. As because the deviation of normal will be considered as a abnormal. So when coming on to female pelvis, as an midwife, we have to know about the anatomy and physiology of the female pelvis. By knowing the basic anatomy of female pelvis only, we can, as an RM, as a midwife, you can able to assist the antenatal mother who should undergo the normal vaginal delivery. So by knowing this only, you can able to identify whether the delivery has been going in a smooth way or in a normal way, or also you can able to identify the emergency. So let us move on to the female pelvis. So this is Bhavani, tutor, obstetric and gynecological department, Triple M College of Nursing, Chennai. So moving on to objectives, at the end of class, the student will be able to define the female pelvis, list out the landmarks of female pelvis, enlist the pelvic joints and ligaments, mention the types of female pelvis, and describe the diameter of female pelvis. It is very important to know about the diameters. Why? Because the normal arrangement of the female pelvis, pelvic bones and the normal diameters will allow you for the smooth parturition. So here comes the definition of female pelvis, and knowledge about female pelvis is a key to midwifery and obstetrical practice as one of the way to estimate the women progress in labor. So we can able to identify the progress of labor by knowing the female pelvis. Next comes the pelvic girdle. You can able to see here this is a pic of pelvic girdle. So it is a basin shaped cavity that consists of two innominate bones. Here you can see the two broad bones, that is called innominate bones. These bones are called as hip bones, the sacrum, and along with these two hip bones we have the sacrum and coccyx. It is virtually incapable of independent movement except during the childbirth, as it provides skeletal framework of the birth canal. It protects the bladder, rectum and internal reproductive organ. We all know that for example, in case of chest, the lungs has been covered with the ribs. So some bones that has been covering these soft organs. So the same thing here, the uterus, the other pelvic and reproductive organs that is getting secured and safely getting covered with the pelvic bone. These two innominate or hip bones are made up of three fused bones. One is ilium, ischium and pubis. So next comes the landmarks of pelvic brim. So we have totally 8 landmarks of pelvic brim. One is sacral promontory, sacral ala or wing, sacroiliac joint, iliopectineal line, which is the edge formed at the inward aspect of the ilium. You can see this is the ilium. So inward aspect of the edge is called the iliopectineal line. This line is called the iliopectineal line, and iliopectineal, which is the edge formed at the inward aspect of the ilium, and iliopectineal eminence, superior ramus of the pubic bone, upper inner border of body of pubic bone, and upper inner border of symphysis pubis. So this is the landmarks of pelvic brim. Next comes the pelvic joints and ligaments. So sacroiliac joint, sacrococcygeal joint, symphysis pubis, sacroiliac ligament, sacrotuberous ligament, sacrospinous ligament, sacrococcygeal ligament and interpubic ligament. So you can see here in the image, you can see the sacroiliac joint where the sacrum and iliac bone joins together, and the sacrococcygeal joint, sacrum and the coccyx join together, and the same like you will be having the sacrospinous ligament and sacrococcygeal ligament and interpubic ligament. So next, four bones articulated at four joints. So these four bones we have, we can able to segregate, or we can able to split the pelvic bone into false pelvis and true pelvis. This false pelvis is nothing but the above the pelvic rim that has no obstetrical importance, which is nothing but during the time of delivery, this false pelvis will not have any change or any adjustment or any movement. Whereas in the true pelvis, below the pelvic rim, that is next to the pelvic rim, inside the pelvic rim, it is a bone defined tunnel that the infant must transverse at the birth. Here is what the main part where the baby will travel through the true pelvis. These here the bones will have the adjustment in order to encourage the smooth parturition. Next comes the plane of pelvis. The plane of pelvic inlet. We have the planes in pelvic inlet, pelvic cavity and pelvic outlet. So we have plane of pelvic inlet, plane of cavity and plane of mid pelvis, that is obstetric outlet and anatomical outlet. So plane of pelvic inlet passing with the boundaries of pelvic brim, making an angle of 55 with the horizon angle of pelvic inclination. See here you can see this is the pelvic brim, that is moves the upper part of the pelvis, that is a pelvic brim. Okay, so passing with the boundaries of the pelvic brim, that makes an angle of 55 degree, that is called the pelvic inlet. And next is the cavity. Here we have touched the inlet with the pelvic brim. Now we have entered into the cavity, that is the tunnel thing. That is true pelvis. In the cavity, it is a plane of the pelvic, greatest pelvic dimension. It passes between the middle of the posterior surface of symphysis pubis and the junction between the second and third sacral vertebrae. Laterally, it passes the center of acetabulum and the upper part of the greater sciatic notch. Right? And it is a round plane with a diameter of 12.5 centimeter. And internal rotation of head occurs when the biparietal diameter occupies this wide plane, while the occiput is on the pelvic floor, that is at the plane of the least pelvic dimension. So nothing but we have already seen about the mechanism of labor. In mechanism of labor, we have the steps called internal rotation, where the internal rotation after the engagement and descent, the internal rotation will take place where the head occurs when the biparietal diameter occupies this wide pelvic plane while the occiput is on the pelvic floor. That is nothing but the head passes into the pelvis where you can able to find out this internal rotation will takes place in the pelvic plane. The plane of obstetric outlet is nothing but this plane. It is a plane of least pelvic dimension. It passes from the lower border of the symphysis pubis anteriorly to the scale spine laterally and to the tip of sacrum posteriorly. It is the plane of the pelvic floor, almost the pelvis floor. We are talking about the pelvis floor, but not the exact out. That exactly out will be coming under in the anatomical outlet. So the head is considered engaged if the vault reaches it. This is a plane where the pelvic axis turns forwards. Next comes the plane of anatomical outlet. It passes with the boundaries of anatomical outlet and consists of two triangular planes with one base, which is bituberous, that is transverse diameter. So we have two planes called anterior sagittal suture and the posterior sagittal plane. So this is the anterior sagittal plane. See, this triangle is called anterior sagittal plane and this is called the posterior sagittal triangle plane. Now the anterior and posterior sagittal suture. See, anterior sagittal plane, it's apex of the lower border of the symphysis pubis. This is the apex of the apex at the lower border of the symphysis pubis. Anterior sagittal diameter from the lower border of symphysis pubis to the center of bituberous diameter. Okay, bituberous diameter. So that is about 6 to 7 centimeter. So anterior sagittal diameter and the next slide I will show you the anterior sagittal diameter and the posterior sagittal diameter. So its apex at the tip of the coccyx. Posterior sagittal diameter from the tip of the sacrum to the center of the bituberous diameter. Here you can see the planes of anterior sagittal plane and the posterior sagittal plane. See, so this is the anterior sagittal plane and the posterior sagittal plane, exact landmark. Now comes the obstetric pelvic axis. Here is nothing but during the time of baby passes or the fetus passes for the parturition during the normal vaginal delivery. Here these bones will get adjusted. So what way of adjustment this will do, so that in order to encourage the smooth paturation, this represents the part that the presenting part must follow for the delivery to occur. The upper part moves downward here approximately in the straight line till the level of scale spine. The trajectory then changes to become the curvy linear path directed forward and downward. So you can see here the axis will come like a forward and downward. Now at the level of scale spine, the plane, this is a plane of obstetric outlet, plane of the least pelvic dimension, that where we can see the levator and muscles. The obstetric axis of the pelvic changes its direction. The head is considered engaged when the vault is felt vaginally or below this level. You can able to identify you can able to feel the head. Internal rotation of the head occurs when the occiput is at this level. Forceps is applied only when the head at this level. You can able to deliver through forceps. At least the head should be at this level, and pudendal nerve block is carried out at this level, and normal level of the external os of the cervix. There are four types of pelvis, female pelvis. According to Cardwell-Mollais classification, they differ in shape of the pelvic inlet, shape of the side walls, character of the subpubic arch. So, four types do exist. We have gynecoid, android, anthropoid, and platyploid. Among gynecoid is the common type where we can see the 50% of women will have the gynecoid, and android 20%, anthropoid 25%, and platyploid 5%. So this is the type of pelvis. The gynecoid, you can see the diameter is a wide diameter, and next is the android, the heart shape, and next is the anthropoid, narrow one, and platyploid is the flat one. So the ideal obstetric pelvis, the brim, how the brim should be, how the cavity should be, how the outlet should be. So the brim should be round or oval transversely. No undue projection should be there. And anteroposterior diameter should be at least 12 cm, and transverse diameter should be 13 cm, and the plane of pelvic inlet it should not be more than 55 degree. So cavity shallow with straight side walls, no great projections of the scale spine, and smooth scale sacral curve, and outlet the pubic arch should be rounded, subpubic angle should be more than 80 degree, and intertuberous diameter of at least 10 cm. So this is a favorable ideal obstetric pelvis. And next is the anteroposterior diameters of the inlet. So now comes the true conjugate, obstetric conjugate, diagonal or internal conjugate, and next is the transverse diameter. So true conjugate from the tip of the sacral promontory to the upper border of the symphysis pubis. Here is what we should say it as a true conjugate, that is about 12 cm, and obstetric conjugate from the tip of the sacral promontory to the most bulging point of the back of the symphysis pubis, which is about 1 cm below its upper border. It is the shortest anteroposterior diameter, that is 11 cm. And diagonal or internal conjugate from the tip of the sacral promontory to the lower border of the symphysis pubis, that is 12 to 12.5 cm, and a transverse diameter constructed to the right angle of the obstetric conjugate that extends across the greatest width of the brim. That should be a 13 cm. So next is the transverse diameter, anatomical transverse diameter and obstetrical transverse diameter. Anatomical is totally out, that is between the farthest 2 points of the iliopectoral line, and it lies 4 cm anterior to the promontory and 7 cm behind the symphysis, and it is the largest diameter in the pelvis, that is about 13 cm. And obstetric transverse diameter is bisects the true conjugate and is slightly shorter than the anatomical transverse diameter, that is about 12 cm. Next is the oblique diameter, right and left oblique diameter from the right sacroiliac joint to the left iliopectoral eminence, and same the left sacroiliac joint to the right iliopectoral eminence, that is about 12 cm, and right and left sacrocortiloid diameter from the right iliopectoral eminence to the promontory of the sacrum and vice versa, that is about 9 to 9.5 centimeters. Next comes the diameter of the outlet, anatomical anteroposterior diameter and obstetric anteroposterior diameter. It is in the outlet. So from the tip of the coccyx to the lower border of the symphysis pubis, that is 11 cm, and from the tip of the sacrum to the Lower border of the symphysis pelvis as the coccyx move backwards during the second stage of labor, that is the 13 centimeter. And next comes the diameter of the outlet, that is anatomical transverse diameter and obstetrical transverse diameter. Before we have seen the anteroposterior diameter. So that extends between the inner aspect of the ischial tuberosities, that is 11 centimeters, and transverse diameter that extends between the tip of the ischial spine, that is the smallest diameter of the pelvis, that is about 10.5 centimeters. So, if the sum of the bituminous diameter and the post-sagittal diameter is about 7.5 to 10 centimeter or less than 15, then the pelvic outlet is contracted. So, this is considered to be an indication to perform the cesarean section. In this type of case, we cannot able to conduct the normal vaginal delivery, right? So, so far we have discussed about the female pelvis, the bones of the female pelvis and the diameters of the female pelvis and planes of the female pelvis and joints and ligaments of the female pelvis and the obstetrical and anatomical uses of the female pelvis. So this would be a very important topic that we should know, only because by knowing this female pelvis only we can able to take care of an antenatal mother who is undergoing for normal vaginal delivery or who is nearing to a parturition. You can able to identify the complication or you can act smart so that in order to prevent the complications and emergencies, obstetrical emergencies. So thank you.